So this is my patient Wheezy. He's 68. He has advanced COPD and some CHF as well. And he was recently in the hospital, and now I'm seeing him for a follow-up visit, and we're getting towards the end of the visit. Okay, Wheezy, so let's just review things. You're going to finish up your prednisone taper and take your inhalers, and you're going to take your Lasix. It's going to help with your fluids. Watch your salt.
I hate low-salt foods, Doc.
Well, Wheezy, I know you don't like the taste of those foods without salt, but if you keep eating all those salty foods, you're just going to end up right back in the hospital again.
So where's all this headed?
It depends on you, Wheezy. If you take your medicines, watch the fluids, watch the salt, you're going to do well. You'll stay out of the hospital. If you go right back and eat your potato chips and drink a bunch of fluid and don't take your medicines, you're going to be right back in the hospital.
I hate hospitals. I wish I could just eat whatever I want and one day go to sleep and not wake up and it's all over.
Well, I know that, Wheezy, that you don't like being in the hospital, but if it's up to you. You got to take your medicines and we're getting, oh my goodness, we're getting interrupted.
Doctor, your next patient is here.
Oh my goodness, I got so behind. Well, Wheezy, enjoy your granddaughter's wedding. Take your medicines, and I'll see you in a couple weeks.
Okay, thanks, Doc.
You're welcome.
So how do you think Dr. Hurry did?
She got out of the room.
It's like her hair was on fire. Did you see any opportunities that Dr. Hurry didn't?
Yeah.
Yeah.
So from the latest to the earlier, you've got a wedding that you're looking forward to, so that says something about what your priorities in life are. You don't like hospitals, so what do you like? You commented specifically about how you envisioned your end of life, at least in terms of what you would like. Maybe an opportunity to talk about some of the practicalities of bringing that about. Those three, I bet there were some others.
I'd use that wedding to coerce you to take your meds. Now, you don't want to show up and have the medics pull you out of the wedding.
I would say, after Wheezy made the comment, I don't want to go back to the hospital, that'd be a great time to talk about advanced directives. Does he have advanced directives? Does he have a pulse form?
Well, let's try that once. I'll be Wheezy, and you say back to me some of what you think you'd say. So, I hate hospitals, Doc. I don't want to have to go back to the hospital.
Yeah, I understand. Hospitals are really rotten. Have you thought where you want to go? I mean, what happens if you get really sick? What do you want to happen?
Well, I'd like to not get really sick. I'd like to get better, but I know that's probably not the way it's going to turn out.
Well, a lot of people like you, in your condition, they kind of decide whether, how they want to be cared for if things get really bad. If your heart was to stop and the paramedic came out to your place, the chance of you walking away from that with any kind of lifestyle is like really close to zip. You want that? You want to go spend 2 weeks in the hospital?
No, but
Have you heard about
gotta do something.
Have you heard about the pulse form?
No, is that like pulse?
No, it's POLST. I forget what it stands for, but basically it's instructions to the paramedics and healthcare providers on how you'd like to be cared for.
That's
You want them to come out to your house and do everything they can, or if you're already
So
dead,
we're starting to get into some of our other role plays, but yeah, I like the idea of just kind of, you saw an opportunity, and I think there are a couple different ways we wanted to present this. One is the health maintenance piece, and that's where we're going to go with the next conversation. But then the other is a targeted opening, the so-called teachable moment. Somebody says something that opens a door, and then how do you do it that you don't have to fear, oh my goodness, if I open that door, I'm getting sucked into a rabbit hole that I may not get out of for 20 minutes. And there are ways to do that as well. So we'll move on to the next stage. Thank you. Oh, okay.
Thank you.
When I was at St.
It's working. Hers is not.
Yeah, can you hear me okay like this?
This is for the room. This is for the camera.
Oh, okay. I get it. That's why it wasn't amplifying. It's for the camera. So Lowell Deitman at St. Peter Family Medicine had a thing if he got running way behind. His MA was supposed to knock on the door and say, Dr. Maya needs to speak with you. And Jessica, do you want to tell us what MYA stood for?
Move your ass.
Dr. MYA. Okay, so we'll go on to the next phase here with Dr. Hurry and Wheezy.
So, do you want to just talk for a second about the 6 steps and kind of how this will demonstrate how you. So in Greg's presentation, he talked about one approach to doing advanced care planning would be to break it into steps. So we're just going to demonstrate how you might introduce the concept of advanced care planning at a busy primary care visit, but not have to do all the pieces of it in one visit.
Yeah.
I guess we'll have to.
Should we pass the mic back and forth? Okay, sounds like.
I think I started.
Chairs closer together.
Yeah. And this is so realistic. Don't you all have chairs about this high in your exam rooms?
All right, Wheezy. Well, let's see. So we talked about you taking your Lasix and avoiding salty foods, and I'm just looking at your routine screening, and I see that you're up to date with your cholesterol and your immunizations. There's one other thing that I like to talk to all my patients about, and that's advanced care planning. Do you know what I'm talking about when I mention that?
No, what is that?
Well, have you ever had to be involved with making decisions for someone in your family maybe that wasn't able to make decisions about their medical care?
Well, my dad died unexpectedly of a heart attack, and so we didn't have to do anything other than call the coroner. My mom, though, she had cancer, and so my brother and I had to do a lot of really tough stuff. You know, we had to decide when to pull the plug and all that. Is that what you're talking about?
Yeah. So it sounds like
Okay.
you do have a pretty good sense of what I'm talking about. Let's see. So today, there's several different pieces to this type of planning, and I'd like to. It's really important for me to understand what's important to you and what your wishes are. So I'd like to spend some time on this. So what I'd like to do is plan to spend a little bit of time over the next several visits. At the next visit, I'll talk to you a little bit about your current state of health, and then I'll have you talk with my nurse at another visit about kind of what your values are and your wishes. And then when you meet with me again, we'll talk about resuscitation and some other decisions.
Okay. Is there anything going on that you're bringing it up now, Doc?
Oh, I'm glad you asked. No, this is no reason to bring it up today other than it's a routine thing that's really important for all adults to have.
Okay.
You never know when something might happen, and it's important to have these plans thought through and have things in place.
Okay. Good. I was worried there's a test result you weren't telling me about, but I'll look forward to that at my next visit.
Okay, great. Yes.
The word resuscitation is a medical word, and I doubt Wheezy knows what resuscitation means. I read an article, I think in JAMA, about using the word DNR, do not resuscitate. You know, we all know what that means, but the general public doesn't. And they said, don't use that word. Don't ask people if they want to be resuscitated. What's that mean?
Good point.
Does Wheezy know what resuscitation means?
Well, Wheezy's been in the hospital a bunch of times for his lungs and heart, so he does know, but I think that Wheezy has become a little more educated than he ever thought he would be.
Did JAMA propose an alternate term?
Do you want, if your heart stops, I don't actually remember the exact article, but I used, if your heart stops or if you stop breathing, what would you like us to do? If the paramedics arrive and you're dead, what would you like us to do?
And that's actually even better, because the whole heart stopping, stop breathing makes it sound so immediate. Dead, they understand.
Yeah. And many of my older patients tell me, if I'm dead, hey, I'm dead. Don't touch me.
When
Well,
you say stop breathing, they're thinking they need a Heimlich maneuver. They aren't thinking the full.
Well, that was partly why I like Dr. Fairbrook's language of, so if you were to die, would you want us to try and bring you back? Because most people recognize bringing back the dead is something that we're not all that good at. And that's different. That's different than if I'm actively dying, intervening to try and prevent it. So, you'll hear the use of allow natural death quite often. I'm mixed on that one because in somebody who really has an advanced illness and death is anticipated, that language works pretty well. I have a lot of people who are DNR but don't want to allow natural death. They want IVs, they want antibiotics, they might even want CPAP and pressors, but they don't want to be coded. And so, again, it gets into that nuance that you brought up earlier. If you have too concrete a directive, it may not capture everything. So you have to think about the language.
So I'd like to just ask, what are your challenges, or is there something you'd like to see us role play? Things that you come up against in trying to do advanced care planning in the office? Family members. We didn't prepare that one.
My thinking about that is, and I bet while you folks are experts, and there are experts at each of these tables who have some experience around how they introduce the concept of filling out a polls form if necessary, or having discussions about advanced care planning. So I'm looking at the healthy 88-year-old
Yeah.
who just had their physical. It's amazing. There's not a thing wrong with you. We know something's going to get you, though. Have you thought about that, or maybe you have some of the phrases you have stockpiled around introducing the topic, and maybe some of the folks around the room have some favorite things they'd like to share as, boy, this works well for me.
We could role play Sandy.
Sandy?
Okay.
Before we do that, I would be interested, are there phrases people use with your healthy, this is so relevant. I saw an 85-year-old with pancreatic cancer who was obviously within weeks to months of the end of life and had no pulse and no advance directive, and I contacted her fantastic primary care provider and did you ever bring it up? And said, no, up until this last month, she was perfectly healthy. But, you're 85, 88, something's going to happen. How do you bring it up?
One point is that you didn't ever mention the family, and I like bringing in the family, especially when the wife or whoever is going to make the decision.
So the comment was about bringing in the family, and especially if you're designating surrogates, trying to have, not only making sure they've spoken to the surrogate, but if it works to have the surrogate come into one of their visits. That's easier for somebody that's a bit debilitated, and the caregiver tends to be a more active day in, day out part, but I think that's important. You have your hand up.
We just added in our review systems, is the last thing added in our review systems about advanced directives. We have that. That's always, every visit we do, we ask that. And then if they say no, then we chime in a little bit.
Yeah, and your interval history form, that's a good place to have a question on there. And if they answer yes, that leads you one pathway. If they answer no, it may lead you another. So this actually is a slightly different approach. This is, do you want to play Sandra straight through as it's written then?
Yeah, I was thinking we'd do steps 5 and 6.
Yeah. So Sandra actually is not your perfectly healthy 88-year-old, but she's very early in an illness. She's got a fairly new diagnosis of multiple sclerosis. But she's not profoundly debilitated, and she's not imminently terminal in any way, shape, or form. So how do you, I think this gets to the core of your question, which is how do you bring this up to the person who might find that it's a little bit weird to bring it up at this stage in their health or illness in a comfortable way? So I'll be, I'll be the doctor, and Sandra is the patient here. She's a 45-year-old woman. She's just now had some limitations in her mobility. So Sandra, previous visits we've kind of been talking about health maintenance issues and managing your primary illness, but one thing we haven't done a lot is just sort of looking at the future. And have you thought much about the future and what that means in terms of your health and everything?
Well, I can't say that I've really talked with my neurologist about it much, but I have thought about it a lot.
So when you think about the future, Sandra, what are you hoping for?
Well, of course, I hope I'll have a mild course of multiple sclerosis. I hope it doesn't get much worse. I've got young kids, as you know. I'd like to be around to see them grow up and be able to be active in their lives.
So right now, what are the most important activities or things in your life?
I would say my family, and also my church. I'm real active at church, and so my faith, my family, church life.
Okay, good. And from what I know about you, you really come across as a very giving person.
Yeah, for some reason, people talk to me, and it's really important to me. I like helping people, and that's an important part of my identity.
Yeah. Well, it's really helpful to me as I think about if you were to have a change in your health status, a really sudden and unexpected change, how would we manage that? And learning more about what's important to you will help guide me. So, I'd like to carry this conversation forward at future visits so that we can really make sure our care plans are set up the best way they can be.
I really appreciate that. I have a cousin who has MS, and she's got it really bad. She's in a nursing home. And so I appreciate the opportunity to talk about that more.
Okay. This is one of those branch points. I often compare good clinical medicine to jazz music. So now you're improvising. Do I say, I'm way behind, we've got more visits planned, I'm going to come back to this thing she just put out there about her cousin, which was a loaded thing, at a later visit? Or am I doing well enough in my time, or I feel this is such a pregnant moment, not a pregnant patient, but a pregnant moment, that I want to grab this opportunity right now because I might not get it again. And so as clinicians, we do this all the time. We're improvising, we're playing jazz, and if we do it really well, it works. And so my own bias, because I'm an in-the-moment kind of guy, I would open that door and say, so tell me more about your cousin, and I bet that's hard for you.
Yeah, it is. She's been in the nursing home. She has a lot of mental effects from the MS, so she gets paranoid. She thinks that the staff is out to get her, and it's been really hard.
Yeah. Yeah, and I would think knowing that you have the same medical condition, that's probably got to touch you a pretty deep place too.
Yeah, that's true. When I found out I had MS, I felt that sinking feeling in my stomach.
Well, it sounds like you've already learned a lot about MS and that your cousin doesn't necessarily predict how things will go for you. But what I'm hearing from you is that it's made you really think about if things didn't go the way you hope. You have some opinions about what you would or wouldn't want.
Yeah, my cousin has a feeding tube, and at first when I found out that she was going to get that put in, I thought, I would never want that. I'd never want to live like that. But actually, it hasn't been that big of a deal, and she's still able to visit with her family and stuff. And so now I kind of think, well, if I ever ended up like that, I think I might be okay with that.
Yeah. And I like the way you're really thinking about the specifics of the situation and how it would fit for you, because there are a lot of people who get feeding tubes. They're probably not helpful, but it sounds like your cousin really did benefit, and so we'd look at it in the moment. Well, I do want to follow up on this conversation at later visits, but again, thank you for allowing me to ask you some difficult questions. And the other thing I could have done at that moment is to say, Sandra, I'd like to talk more about your cousin at a later visit, and then at a follow-up visit brought it up. I mean, you don't have to do it all at once. You do recognize you might miss that window of opportunity, but if you're already a half hour, 45 minutes behind, you have to make those decisions in the moment. Leighton.
Is in a young lady like this with a terminal illness, is this the time to ask her to take home the brochure of the 5 questions? Or is it too early in her illness?
That's a really good question. I actually would be open, maybe not at this visit, but at this stage in her illness, I think it would be appropriate. The 5 wishes gets into how I want to be treated, what I want people to know about me, those sorts of things, designating her, in this case it's going to be her husband as her surrogate, really laying those things out. It would be premature for a pulsed form. It might even be premature for the hard choices for loving people, because that book is really written for people who are facing death more imminently. But the 5 wishes is a more proactive document about what I do and don't want, expressing my values, and taking steps to assure that if things go bad, suddenly my values will be honored. So, we want to do one last one here on Sandra?
Sure.
Because I know you still have some business to take care of, right?
Just a little bit after this.
Yeah, okay.
We'll be wrapping up pretty quickly.
Good.
That-
So, did we have...
We had another one on Wheezy.
Okay, yeah, actually, Sandra, we captured a lot of it in that post, the part about the cousin.
While you're thinking of the last one, I'm going to pose a challenge to those of us that are still here in the meeting, in that one way to really be familiar and to ourselves role play this is to challenge challenge you to go home and go through these steps with your spouse. And to listen to your spouse. Or how many people have gone through the 5 wishes at home and get that competitive spirit going here on this?
Yeah, I spent, I'm embarrassed to admit how much time I spent in this line of work before I finally got around to doing it myself, and it was the 5 wishes, and that's just, it's a document that really lends itself to it very nicely. So the last thing we're going to do is people, you brought up the whole issue of resuscitation there, Leighton, so we're going to kind of loop back into that a little bit, and so we're going back to Sarah's going to be Dr. Hurry, and I'm Wheezy Jones.
Okay. So, Wheezy, you and Nurse Val talked about your values and ideas about a meaningful life at your last visit, and your power of attorney. I see that you asked your brother to make decisions for you. And I did talk with Nurse Val about your conversations with her. Today, I'd like to talk about CPR with you. Do you know what CPR is?
Well, it's that thing where they thump you on the chest and try and make your heart beat again.
Yeah, the nurses and doctors push on your chest and to get blood to flow through your body when your heart's not pumping properly, and push air into your lungs to get oxygen. Let's see. Oh, you're supposed to say I've seen it on TV.
Oh, sorry. Well, I've seen it on TV. You know, it's pretty impressive because, well, I'm embarrassed to tell you I watch Grey's Anatomy, but, you know, they often works. It's pretty good stuff.
Yeah, on TV it works on 4 out of 5 people. But actually CPR was designed for people that have a sudden unexpected death, like in a drowning or a sudden heart attack in an otherwise healthy person.
Really?
Yeah, and in real life, in patients like you that have other illnesses, and patients in the hospital, only about 15% of people actually walk out of the hospital that get CPR. And in nursing homes, the number's even smaller than that. Some studies have shown only about 2% of people in nursing homes actually do well after getting CPR.
Wow, I would have never guessed that. Well, what do you think, Doc? I mean, I don't want to just throw in the towel. I'm not ready to give up. So what should I do?
Well, knowing what we've talked about at other visits and what you talked about with Nurse Val, I know that you still have a lot of living to do, and you've got your granddaughter's wedding coming up, and you enjoy spending time with your family and your grandchildren. So I think that it makes sense to keep doing everything that we can to help you live the way that you want to. But when the time comes that your heart stops or goes into an abnormal rhythm, or you stop breathing, we know that you have serious lung disease and heart disease, and that we can't fix those things. And so I would not recommend that you go through CPR, because I think that it could cause you a lot of harm without really offering you any benefit.
So then what do I do?
Well, when that time comes, Wheezy, there's a lot of things that we can do. There's a lot of things that we can do to make sure that you don't suffer, to make sure that you can breathe comfortably, and that you don't struggle for air, and that you don't suffer in pain. And so I think that on your form here, on your 5 wishes, we could check do not resuscitate, but know that we'll still do everything right now that we can to help you live a good life.
Well, it's really important, because when I can't breathe, I just freak out. You know, it stresses me out terribly. So I've got to know there's something that can help me, you know, when I get that really, really bad feeling like I'm underwater sort of breathing problem.
Yeah, I've seen that. That's really uncomfortable for you, and that's very common. It's scary when you can't breathe, and people get anxious, and then they have even more trouble breathing, and it ends up sometimes being a hard cycle. It seems like you've just had a couple of hospitalizations each year, and that you've been able to push through those and still feel like you have a pretty good quality of life. If things get to the point where you're finding that you're spending more time in the hospital than is really acceptable to you, or that you're having a lot more of those scary times when you can't breathe, we can talk about shifting the focus of our care to really focusing on your comfort. And there are medicines that we can give you to help take away that air hunger. That our focus might be a little more on comfort for the time they have left and a little less on trying to help you live longer.
Well, it's nice to know that'll be there. I don't feel like I'm ready to go there yet, Doc. I still want to go to my granddaughter's wedding, and I've got some projects in my shop I'd like to finish up. But if I find that I can't get from the house down to the shop, or God forbid I need to get one of those god-awful little electronic scooters I see all these old people using in Walmart, you know, I think then I would probably be ready to do what you're talking about.
Well, I'm really glad that you shared all that with me, and I think it'll be important on your 5 wishes document here to write those things down so that if your brother has to make decisions for you, he'll have a good understanding of what's important to you.
Well, thanks, Doc.
Sure.
So, thoughts on Wheezy and Dr. Hurry? Does that seem realistic? Does it seem like it's manageable in the flow of a clinic practice?
You have the mic.
Yeah.
I think so. I might interject. A couple points I try to make with my patients is they may not be quite ready to make that decision right at that instant. And I try to make the point that you're not necessarily going to have to make that decision right now. And the other point I like to make is any decision you make can be reversed
Yeah.
later if you have to change a part or if your condition changes and so on. So I like to put those 2 points.
Yeah, I think those are both. Could you hear those points over there? Good. Yeah, I think those are both valuable points. And one of the ways I'll sometimes address the second point is to say, you know, we're looking ahead without really knowing what's going to happen. And so when the time comes, or if the time comes we have to deal with it, we may need to make some decisions differently. But this at least gives us a good sense of direction. And I liked what Dr. Hurry did here too in tagging the brother and really kind of reminding me to talk to my brother, because so many people have designated a durable power of attorney and never talked to him about it. And so, I think you brought it up, bringing the family member in. We didn't set up role plays with family members. We have a very small cast. And so, you know, I think that would be another thing, is to then bring in husband, wife.
Like I said, you could say, well, why don't you talk to your family and come back and
Yeah.
talk about it again as a closing?
Yeah. And that, well, his comment was to talk to your family and then maybe bring them back at another visit. So, yes?
Just really quick, it's really interesting what you're talking about here tonight, because tomorrow, just to let you guys know that your home health and hospice agencies are talking a lot to the public. So, I mean, I'm doing a presentation tomorrow to the public that's almost exactly this, on how to talk to your loved one, but also interacting with your physician. And a lot of it is the same thing. So we're educating people about the pulse form, about 5 wishes, about those same topics. And so hopefully what you're gonna see is when you bring this up, it's something that they are familiar with. And so it's kind of cool that everything that's being talked about here tonight is things that we're also doing in the community to help support all of this. So it's amazing how it just mirrored a conversation that we're gonna be having in the community tomorrow.
Yeah.
So thanks for having the conversation.
Yeah, thanks, Julie.
Dave Hughes runs the program with the Chronic Disease Self-Management Program, the Stanford University program. A significant amount of week 5, or I think it is, talks about these things and talks about talking to your family about what you want and communicating those things so that they don't make decisions under duress. And they do a beautiful job of talking about the pulse and DNRs and all of those different things. And these are designed for people with chronic diseases, not necessarily imminently dying, but you have a chronic condition. And part of managing your chronic condition is end-of-life planning. And they have a real nice little blip on it that's handled in a very matter-of-fact way as just part of the program.
And I didn't include the reference anywhere, but if you're interested in this sort of thing, the columnist Ellen Goodman has created something called the Conversation Project. And if you Googled it, and it's her entire thing is kind of what Julie was talking about. Her focus isn't on healthcare providers, it's on the public at large, and it's encouraging people to have difficult conversations with their family members so that, again, when things come up, this isn't an unfamiliar topic. Leighton, you had your hand up.
Yeah, I was just gonna share, in the last couple of months, I had a really wonderful experience. One of my long-term patients had his 3rd hospitalization for failing to thrive, heart failure, mental decline. And ended up going to a nursing home. I got a phone call from the doc who was taking care of him at whatever nursing home it was, and says, you know, he's ready for discharge. You know, we got this pituitary thing on a CT scan. We got this, we got that. You know, this guy was out driving his tractor 6 months ago and really enjoying life. He's 87. And I said, I'd be happy to have him come back and talk to me. He said, you know, send the whole family. We actually had a little talk in my largest exam room. And you know, he'd been hospitalized 3 times. Every time had to go to a nursing home to get stronger. And by the time I saw him, he was just 1/4 of the guy I'd seen 6 months ago. And it was just such a wonderful call that the guy discharging me from the nursing home called me up and said, gee, I don't know if I can have this conversation. He said, hey, I'm happy to have the conversation. I know what this guy wants.
Yeah.
Send the family and I'd be happy to sit down. And you know, we had the talk. He was in hospice the next day, and about 2.5 weeks later, he passed away very comfortably at home. You know, just a really nice transition. You know, he didn't get the neurosurgery to figure out what this pituitary lump was, which wasn't going to change anything. You know, his heart, his brain was gone. You know, he was passing on. So that communication, that 90-second phone call was just so valuable.
And what a great service. And I think that's one thing in the hospitalist era we really need to improve our game on, is that communication between inpatient and outpatient care. One of the standards now that's palliative care programs in the hospitals are going to be held to is that they can assure prior to discharge there's been a provider-to-provider communication, not a faxed sheet, not an electronic communication, but a human-to-human interaction. It may be the hospitalist to you, it may be the palliative care nurse practitioner to you, but that somewhere or other there's a direct communication that's really critical.
That 2-minute phone call, I don't know about other people, but I find those 2-minute phone calls incredibly valuable, much better than reading 5 pages of discharge summary and history and physical and trying to dig out what happened.
I think we
Right.
should thank Dr. VandeKieft and Merrifield. And thank you all for your great attendance to this.